All right. The beautiful thing about going live is things don't always work the way that they've been rehearsed and practiced, which is no big deal. We're resilient. We will bounce and just get right back to it. So it was a great opening. You missed a great opening. And basically, this is what I said. One, thank you for joining us. I know your time is really valuable. We have 90 minutes of action-packed content, really good stuff that you'll really appreciate because it's all about content. There's nothing else. There's no sales. There's nothing else. And that's really why we are formed. So we are a chief digital officer organization formed by chief digital officers. And everything, the content, everything's curated really around the chief digital officer and what we all deal with on a day-to-day basis as we serve in health and life sciences. So I do want to acknowledge the founders, and you've seen the founders on the registration site for Digital Voices, and there's 13 of us, and we cross all aspects of health and life sciences, and we realized, wow, we don't really have an organization where we can sort of have iron sharpens iron and just help one another and lift one another up and share ideas. And then part of the issue with digital transformation in healthcare is that we're so siloed. So payer people only hang out with payer people and providers with providers. So this is a CDO organization that cuts across all of health and life sciences. So if you look at the HC13, which the founders are called, they're from the continuous spectrum of people in health and life sciences. If you want to join us, everything's free because it's there. Again, there's no gimmicks. Everything's free. So we leverage LinkedIn, so you can find us under Digital Voices. If you want to join us, you're definitely welcome to. So 90 minutes, action-packed, amazing lineup. Engage with us. One of the things that made Digital Voices 2020 so unique and popular was the engagement that happened in real time. So as you're watching and streaming, you can engage directly with us. So our first speaker, let's jump right to our first speaker. It's Dr. John White. He's the CMO of WebMD, and he's fascinating. I've had him on my podcast. I've had him on a webinar. And not only is he a practicing doc, but he's got all this experience and background working in the federal government, so he understands that angle. And then really unique roles, not just WebMD, but prior to that, like the Discovery Channel. I mean, how cool would that be, working for years as the chief medical officer for Discovery Channel? Anyways, fascinating individual, great insights, even things that really stretch me on patient centricity, stretch me beyond what I thought about patient centricity. And we call it This Is the Way, as a nod to our Mandalorian friends. So watch and engage with Dr. John White.
Hi, everyone. I'm John, and I want to talk about patient centricity, a little bit about the past, the present, and the future. 50 years ago, we didn't even have the concept of patient centricity. Everything was focused around the physician. Physician parking, physician lounges, physician lunches, right? We had to keep the physician happy. And in some ways, the patient was almost treated as if they should be grateful that they have the doctor's time. And when you think about that, really, that's how we view the interaction? It really, as I said, was focused on keeping the physician happy at all costs. I think where we started to see change was during the HIV epidemic, when patients demanded a seat at the table. They wanted to be involved in drug development, drug approval, drug costs, how care was being delivered. And that made enormous progress when they got a seat at the table in terms of how we interact with patients, how we view patients. But you might be surprised I'm going to say this. In some ways, it was only a seat at the table. In some ways, it was a sense of tokenism, right? We'll find a patient. Let's talk to a patient. We'll put a patient on a committee. And there's always one, right? There's never multiple ones. I'll tell you, even when I came to Washington in the very late 90s, and I was responsible for helping put together the Medicare Coverage Advisory Committee in its first iteration. And it really was dominated by physicians and economists. And the last minute, it was decided, let's put a patient on it. It wasn't front of mind, it was actually the last component. And then there was a scramble, again, to find a patient. And there's still value in that. I don't want people to think I don't think that has value, but it's more than just listening to a patient's story. It's really about finding a systematic way to engage with patients. And I think we started down that road about 5 years ago when the US Food and Drug Administration created this process called patient-focused drug development. And we really started to have this concept of patient-centricity in our lexicon. And what patient-focused drug development was all about was, how do I measure what's clinically meaningful to patients? Remember, I talked about how doctors would rate how patients were feeling. We'd ask the doctor how the patient was instead of asking the patient, even on clinical trial sites. But we stopped that with this initiative and really wanted to understand what's important to patients. And how does that affect drug development? So you could take a condition like Duchenne's muscular dystrophy, a neurologic disease. And there's a 6-minute walk test that we often use. How far can a child walk in 6 minutes? The patients would tell you, you know what? It doesn't really matter how far I can walk. What I really care about is upper body strength, upper motor strength, the ability to feed myself, the ability to change myself. That can be a validated measure. We can utilize that tool and have reliability in that measurement to impact drug development, to impact what's meaningful to patient. And unless you talk to patients, unless you engage with them, how would you find out? It's not just about talking to the clinical trialists or talking to the doctors or talking to the drug developers. So this is huge progress, especially when the regulatory agency says this is important. And we started to see much more engagement with patients, engagement with consumers. But in some ways, we haven't utilized science to guide patient engagement. So what do I mean by that? Many patient advocacy groups, well-intentioned, put surveys on their sites to ask patients how they're feeling, to ask people suffering from different diseases to talk about it. But as a regulator, as a federal agency, as drug developers, how do I utilize that information? How do I know that it's representative of the patient population in general? How do we use science to advance patient centricity, patient engagement? Because it's not about putting one patient on a committee. It's not about asking a couple of patients how they feel or what's important to them. It's really using the rigor of science to understand what's important to patients and stratifying that data by sex, race, age, ethnicity, socioeconomic status, recognizing that different patients, depending upon where they are in their disease condition and other factors, are going to feel differently of what's important to them. And I think part of the challenge is, surveying people, understanding their thoughts and emotions is a social science. And in medicine, it's primarily a biologic science. And there's really kind of a tension or a friction between these two sciences. And honestly, I think a lot of people in the biologic science looks down on the social science. But then those people that are surveying patients and talking to patients aren't doing it in a systematic way with rigor. And it's almost as if we've thrown out the social science. And in some ways, well, I'll just survey more patients and get their opinion. And it has to be more than that, because we want to understand whether it's in drugs or whether it's in different treatments, is there a variability of response based on these certain factors, based on sex, based on age, based on race and ethnicity? And we won't find that out unless we engage with patients to understand that. It's the same with Medicare coverage as well, how do we understand what's important to patients? I think COVID has fundamentally changed everything. I talked about how HIV has made an impact, how patient-focused drug development at the FDA has made an impact, but COVID is really making an impact. And that's where patient centricity has come front and center. So literally, patients were not able to go to the hospital, not able to go to the doctor's office. So we had to bring care to the patients into their home. So able to do lab tests in a patient's home, able to do over-the-counter tests in a patient's home, even able to provide chemotherapy that we never thought we could do in a patient's home. And we all know about the role of telehealth and telemedicine. I don't even have to leave and I can engage with my doctor through a Zoom call or through other, conferencing, video conferencing. We didn't do that in 2019 or even early 2020. But what that has done has in many ways put the patient in charge. So it's about the patient's convenience. It's about the cost to the patient. And it is about control for the patient. And I can decide if I have joint pain and I want to see a rheumatologist, I can do a telemedicine visit today. Why should I have to wait several weeks? Just as we now have different expectations of grocery shopping, of retail, we're going to have that same expectation when it comes to our healthcare. I've been talking a little bit about the emergence of what I call DIY, almost this do-it-yourself approach in terms of healthcare. I can download a bunch of apps, right? I can order a device and do my own refraction on my phone. I can order a device to look for ear infections in my kids. Why do I have to go to the doctor's office? I can download an app and take a picture of a skin lesion and pay a small fee and get a read today from a dermatologist versus waiting 6 months in some areas of the country for an actual appointment. And why is that? Patients aren't willing to wait. And why should they wait? We have done a disservice to patients in that way. So COVID has taught us we need to focus on the patient and what the patient's needs are. What's convenient for the patient? Why should they have to drive 20 minutes, wait in a doctor's office 30 minutes for a 10-minute appointment, and their whole morning or their whole afternoon is gone? When in many ways, they can do more care at home, they can do more care remotely, and they can have more control of their care. But the key is we still want to tie this information back into the healthcare system. I want to use all of your smartwatch data that you want to give me and address those issues of what we call interoperability, so it can communicate with me as your doctor. It can communicate with other people in the healthcare system, so I can make sure I provide you the best care and the care that's personalized. We're all talking about precision medicine and personalized medicine, and patient centricity contributes to that. Get frustrated at times when you think about it, that the airlines, the hotels, they're very knowledgeable about your preferences, about your choices, about the way that you search for travel and leisure. But when it comes to healthcare, it seems as if we don't have any sense of personalization, any sense of trying to match my care to my specific needs without a lot of work on the part of the healthcare system. And we need to change that. We need new tools. And I think the digital health explosion is going to continue to change that. And we're going to have more and more tools that patients can use at home, they can use on their cell phone, and that doctors can also use. But they need to communicate. And too often the tools haven't communicated. Think about it. You want to send your smartwatch data that I referenced to me? That's not easy to do. How are you going to send me your sleep data? How are you going to send me your physical activity data? That's useful information that I could use to help manage your care and make it personal to you. But we need the systems to do that. We also need the mindset. So despite the fact that I told you we're really, I think, moving into an area of patient centricity, we need to get the health providers on board. We need to get other health professionals on board. And we need to also get more patients to recognize that they're the focus of our care. And sometimes you need to be the squeaky wheel to get the best care that you deserve, because we really need to have the patient at the center of things. So I'm very optimistic. I'll be honest, there have been some false starts along the way over the last 20, 30 years. But I feel now with how COVID has changed the way that healthcare is delivered, has changed expectations, has changed the way we use digital tools and information. We really have an ability to make patient centricity, focused on the patient, the premise, the focus of healthcare. I'll be interested to hear what you all think.
All right. Thank you, Dr. John White. That was awesome. I saw a lot of engagement taking place. So don't forget, you can interact directly with the speakers during their sessions and, pick their brains, learn more. It was awesome. I myself was challenged, as I mentioned online, when I first met Dr. White. I thought, oh, I'm pretty good at this patient engagement aspect and strategies and patient centricity. But after listening to him and give some examples, I was like, oh man, I'm just level one. And he's definitely has a lot of great ideas to take me to the next level. So we're actually incorporating a lot of that in our own work, as I'm sure many of you are already doing, or at least he gave you some food for thought in terms of what you could do. So our next speaker is Heidi West. Heidi leads healthcare for Zoom. And Heidi and I go way back, actually. So it was kind of funny when we were talking. We also did a podcast together and webinar, and we were chatting about years ago when she worked with Cisco. We were looking at some really, technologies that are sort of mainstream today. But when we were chatting about it and trying to implement some of these things, I don't know, 10, 15 years ago, they were definitely sort of futuristic. And so she and I have always kept in touch and always had the same angle about how do we disrupt healthcare? How do we really leverage technology to help save lives and increase quality care, and then help with the experience that Dr. John White just spoke about. So you're going to hear Heidi talk a little bit about the new, where we're headed, the new medicine in the age of digital. And I think you'll find her talk just as insightful. So let's welcome Heidi.
Thank you, Ed. What does virtual mean? In the dictionary, virtual is defined as not physically existing as such, but made by software to appear to do so. So there, but not there. Let's go back a year ago in March when our worlds changed overnight. Entire companies of employees were sent to work from home, many of which were not prepared to do so. Our entire education system had to shift overnight, and teachers were asked to teach their kids from their own homes into their students' homes. My husband is a teacher, and I remember how hard it was for him and how important it was for him to stay connected to his students during that time. Family members were isolated and entire communities were shut down. And in the midst of a pandemic, we were forced to shift to a different way of both providing and receiving care. Everything went virtual. I remember being fearful and not knowing exactly what the future had in store for us. But at the same time, I remember being inspired every day by the resilience, the creativity, and the innovation that surrounded us during that time. At Zoom, we have an internal chat named Cool and Inspiring Stories. And I still go and scroll through it pretty regularly just to be reminded how creative we are when we have no choice. Whole new businesses were created or shifted and markets expanded. We were creative, resilient, and adapting. For virtual care, telehealth isn't new. It started back in the 60s in our space program. But regulatory limitations, pay parity, and tech limitations, consumer and provider confidence really limited the acceptance of telehealth. When we had no choice, we shifted and it worked. Wasn't perfect, but we worked. And it worked and we showed our resilience. There were 31 emergency policy changes, and although there's no confirmation of what will and will not stay in place, most analysts, industry experts, and even policymakers agree that there is a place for telehealth. I think the one emergency policy around HIPAA is the one we all agree needs to be tightened up and make sure that we have patient privacy and security in top of mind. Prior to COVID, about 30,000 visits were done on telehealth a month, maybe about 5%. During the peak of COVID, that was up to almost 95%, depending on who you talk to, but it was really peaked in the mid to high 90s. Now we're seeing somewhere around 20 to 40%. And I think we're in a normalization phase where everyone's trying to determine when it makes sense to do a virtual visit versus inpatient visit. It would be a shame if we don't embrace the last 10 years of innovation and digital transformation that we experienced in just 10 months' time and go backwards. Virtual care is more than just a physician to a patient. If you think back to the definition in its simplest of terms, it comes down to any interaction between two or more people that are in separate locations. One is seeking guidance on their health, and the other is providing the care. If you think in these terms and think about an entire patient's journey, communication has the potential to enhance every encounter along the way. Allow every interaction to be reconsidered. Can this be done virtually? And could video enhance the experience for the patient? We heard incredible stories last year of how virtual care did more than just replace an in-office visit. With limited PPE gear, we heard story after story of a virtual visit where the patient was in the patient's room holding an iPad and care was being delivered just outside the door to help with the PPE gear shortage. We heard how family members were able to speak to loved ones who were in quarantine and in some cases improve their care just based on that connectivity and the connectedness with their families. Specialists were able to expand their care and see more chronic conditions be treated at home. People were able to stay healthy and stay home as much as possible. We found new ways to extend care to rural and underprivileged populations. We extended care into communities and made quality care more available to everyone. We saw net new populations embrace mental health. The stigma of seeking mental health can be limited with this degree of anonymity in virtual care. You may not necessarily run the risk of running into your therapist in the pharmacy or the store. And it allowed for a way to engage in a new and important way, especially this past year. In talking to a friend of mine who runs an FQHC, I was reminded that in some cases, mental health in-person visits become a safe space for the patient. So while we look at virtual care as an enhancement, it's never meant to replace the need for in-person care. We saw opportunities in care coordination with sharing of information we've never seen before. And if we continue sharing information, it gives us the opportunity to enhance all the care delivery and an opportunity for treatments and cures. It allowed us to bring teams together regardless of their location. We learned a lot last year. So now we fine-tune, we innovate, and we adjust. Physicians are more comfortable with the technology, but even more importantly, consumers are more comfortable and familiar with the technology. It would be incredible to take all that we've learned and allow telehealth to finally bring us to a point of focusing on value-based care in this country. It could become the great equalizer in providing equitable care for all our citizens. And it can even extend care into some of our most rural and isolated populations. Studies and examples are saying, yes, this can be done. Surveys are showing high NPS scores. People feel more engaged with their doctors, and there's a belief in this quality of care. There's some things to consider. Financially, the HFMA Financial Sustainability Report, it showed that a physician revenue on a 4-hour virtual visit block was 22% higher than a similar office block. And I understand that those can vary slightly based on your experience, but it does show that it's higher. It's important to understand what impact payment changes will make. So understanding a payment tracker and knowing that you're leveraging the CPT codes to maximize your potential revenue are important. If you're managing your virtual visits with your in-person visits, consider leveraging some of your physician's assistants and nurse practitioners to augment your virtual visit timeframe. You want to make sure you build KPIs specifically between an in-person and virtual visit so you can get a sense of what's working and where it makes sense to go in person or virtual. Things like no-shows for in-person versus virtual, overall revenue, average wait times, patient sat, ED readmit days. A lot of different KPIs you can be leveraging to understand when does it make sense to use virtual and what does it make more sense to be in person. What's the operational support model? You need to consider the scheduling, the operations component, as well as the communications with your patient. There's also an entire marketing and branding component to leveraging virtual visits to enhance your experience and your connection to your community. What is the clinical opportunity of virtual visits, virtual care? Primary care is probably one of the biggest opportunities that you see if it's refilling prescriptions, monitoring chronic conditions, and addressing some simple and non-acute care, if that makes sense. We're seeing remote patient monitoring exploding with the opportunity of treating people and allowing them to stay at home. From a clinical trials perspective, we're seeing the footprint of those involved in clinical cares expanded because you can actually monitor trials with people at home. We've learned that solutions need low bandwidth and they need to be adaptable and familiar. We as consumers are all asking ourselves, what can I manage at home? So now we realize that healthcare needs are more than just diagnosis and treatment. We need to focus on our health and our care. Leveraging IoT tools and all the enhancements and innovation that have happened recently, especially this past year, will allow us to get ahead of acute care occurrences and allow people to stay at home. Now that physicians are in some cases ready to go back in the office and feel compelled to revert to traditional care models, there's a couple things to consider. You want to make sure you embrace this concept of a video-first virtual care mentality. Think of it as a time to extend and expand your care. I know there's still a question of reimbursement and quality of care, but you don't want to lose sight of the possibilities and the other considerations I'll go through now. There's really 3 C's when it comes to considerations of virtual versus inpatient care. The first one comes down to the consumer. You don't want to underestimate the consumer. Consumers have more power than they even realize right now. But last year provided a lot of insight around convenience, confidence, and choice. Now I have to decide if I need to go to a doctor, do I want to travel through traffic, have to take a half a day off, sit in a waiting room where we're all a lot more acutely aware of airborne illnesses, only to find out I have to see a specialist and do a lot of other visits taking up more time away from my day? Or can I do a virtual visit and really streamline the needs that I have in order to get the care that I receive? It's a lot to think about. Do I believe in quality care during my visit? Back in June of last year, the University of Penn released a study that showed 80 to 85% of patients and 85+% of providers rated telehealth visits as good or better than in person. And that was back last June when there was still a lot we were learning. It does point out that our elderly and our minorities did rank lower, but still above average. And it just shows areas that we can still improve. You don't want to forget that family members now have an opportunity to be involved. They can rally around a patient's care regardless of their location. I know last year when my husband was having a procedure, I had to sit in a parking lot and there was really no way to engage. This was early on. If I could go home and know that I could still be involved in the progress and the treatment during care, it'd be a lot more convenient for our family. The second C is competition. There is a lot of competition that's been introduced this past year to traditional care models. You want to know with consumers having high deductible healthcare plans, they are looking for low cost options. There's an entire direct to consumer. I don't think you can watch TV without seeing a way to engage with the patient directly that serves as competition. And it also provides the convenience and choice that consumers are looking for. There's also the retail health. If I'm needing to get a pretty basic thing done and I can pick up a prescription and possibly pick up a few groceries along the way, I may consider an option besides my primary care physician. Long gone are the days that the primary care provider serves as the front door to a committed patient throughout a care delivery system. Options and convenience really do need to be considered to retain your patient population and possibly even attract additional patients. Newer generations have expectations that don't even include traditional care models in many cases. So the ability to adapt to this new way of thinking, convenience and availability have to sit at the core. The third and equally critical consideration is cost. As I mentioned earlier, we still have to understand the long impact of cost. But there's no question, with the healthcare industry taking a beating last year, we were already in trouble with almost 20% of our GDP going to healthcare costs. When comparing to other countries, our costs and outcomes didn't align well. So it's important that we collectively build forward and not go backwards, helping recognize the value-based care and start managing some of the costs of care. If you imagine a disaster or the need to get into a rural population, historically, we either loaded up 18-wheelers and had doctors and caregivers join and go into some of these areas. But now maybe we load that same 18-wheeler or a mobile van with kiosks and someone to help technically engage in a virtual visit and allow for whole families to come and receive whatever specific care they need, whether it's a specialist or primary care. It expands care beyond just those who are physically present. It's not just cost pressures. It has to do with what the patients need and want as well. We saw unprecedented innovation this past year. Can drones play a new role in care and delivering care? Not just about delivering medicine, but doctors could possibly look and see an area and understand what care is necessary before they even engage in that area. The same article from Penn Health actually commented that internet needs to be available and seen as a healthcare need. It could help bridge both the education and the care digital divide. So focus on how to get internet to all of our citizens is critical. So to summarize, the pandemic definitely catapulted digital transformation into hyperdrive into healthcare. I spent a lot of time talking about virtual visits, but it's important to think about how virtual can be leveraged throughout a patient's journey of health and have something that's familiar and connected throughout their care. If you can build a sustainable telehealth strategy, you want to build your financial, your operational, and your marketing models to support it. If you feel compelled to return to just in-office visits, don't underestimate your consumer, the competition, and cost pressures. It's not just your cost pressures, but the patient's cost pressures as well. We saw unprecedented innovation, resilience, and adaptability this past year. And it's our responsibility to focus on equitable care for all of our patient populations. Don't think of video communications as a mirror. Think of it as a window that opens your world to endless possibilities. Thank you.
Thanks, Heidi. That was really spot on. And I love the chatter too on the topics that you were bringing up, especially towards the end on health equity and social equity, and how do we leverage tech in such a way that we can impact both. I was just thinking, I just came back from a trip to Peru, and we were like high above the Inca Trail. So for those who've done the Inca Trail, we were at another 1,000 meters above the Inca Trail. And there's not many people up there, right? It's around 16,000 feet. And there's several villages at around 14,000. And so we didn't run into a lot of people, as you might imagine. And one time we did. So we stopped and asked this person what she was doing. We were just chatting. Our guide spoke the native language. And she turned out to be a nurse. And the only way that they could deliver care is she would walk for hours and hours and hours overnight to reach some of these really remote places. And we were just, my wife being a nurse as well, we were just talking about, wow, what an opportunity. Obviously, it would be difficult to do broadband, but certainly drones or other sort of technologies. Anyways, we're very privileged, those of us who are part of this, the CDO organization, part of this Digital Voices, that we can leverage these technologies, and as we should, and continue to do so. And there's so much more to do just globally. But I really appreciate your insights, great ideas on around KPIs and just the business model of doing this. And again, tied back to Dr. John White on patient-centricity. And at the end of the day, it's really about the experience for both the patients and the clinicians. So now we want to turn to another friend of mine. This is kind of fun because everyone's like a friend of mine. We're going to hear from Amit. Amit is another awesome person. He is the Chief Digital Officer for GE Healthcare. Prior to that, so interesting, he came from Cisco and out of India, where he led Cisco and a lot of their growth in India, and he has patents. So he's an engineer and he's a creator. He's very innovative. And then he came over into healthcare. So again, I think I also have had him as a guest on my podcast, maybe a webinar, and very insightful person. And I learned a lot from him as well, both on a personal and professional level. And we both have a connect back to India as well. So he's just a great person. And I think you'll appreciate the talk that he's going to share about platforms. And so how do we leverage platforms like, a Zoom platform as an example in order to really get going? So this is really about digital healthcare in a platform economy, and with my friend and the GE Healthcare CDO, Amit. Welcome, Amit.
Hello, everyone. Good morning, good afternoon, good evening. My name is Amit Padnis. I'm the Chief Digital Officer for GE Healthcare. We're going to talk, about digital healthcare in platform economy. And you know what? I want to really start with a very personal story. My elder daughter is actually a doctor, and she's in India right now. And unfortunately, the situation, as you can see, hopefully from the news and things like that, is actually, we could say terrible at this point in time. She's been going to the hospital at 8 a.m. in the morning. She's there till 2 a.m. every single day. Can't even get hold of her. But when I get hold of her, all she's saying is, why do you want to know what's happening? It's terrible, right? And I think one of the biggest challenges that they have is, what they're seeing at this point in time is not a wave, it's actually a wall, literally, that's hitting them. And there are just so many patients, okay, that they need help and desperate help to understand who are the ones who need to be taken care of first. And I think, if you really step back and think about it, this is really the crux of what digital or other technologies within healthcare needs to be able to solve for, which is get a little bit more productive by using data and analytics, so that we could zero in on the right patients, and more importantly, when we zero in on the right patients, we can actually give insights to clinicians as to how to effectively drive outcomes for the patients in a positive way. So look, we've as a part of my role and my business, we talk to customers globally. and I'm pretty sure that you will recognize this very well. That across the globe, there are some significant challenges at this point in time, right? And this, by the way, was true even pre-pandemic, and I'll talk a little bit about what's happening through the pandemic, obviously. But first and foremost, in healthcare today, access is itself a big challenge. Okay, more than 3.8 billion population across the globe doesn't have access to basic healthcare, even as we speak, in spite of all the advancements that we have done, instead of all the money that has been poured in, instead of all the technologies that have been developed. The reality is that 3.8 billion population doesn't necessarily have access to basic healthcare right now. The second thing is there is a significant amount of money that is being spent on healthcare, almost $6 to $8 trillion. In the US, the spend is $3 trillion. But out of the $3 trillion, $1 trillion goes waste. And that wastage happens because of many reasons, right? It could be wrong stratification of patients, it could be diagnosis, it could be treatment paths. But there are many reasons why there is a significant amount of wastage in the system. And it is important to use technology and use digital and analytics and AI to try and really reduce the wastage significantly, because every dollar that you save from a wastage perspective is a dollar that's available for good investment in future. So I think that's a pretty significant challenge. And if you sort of categorize that further, you'll realize that there are two sets of issues. There are a set of issues related to operational optimization. There's another set of issues related to clinical optimization. So both of those are sort of equally important and equally challenging. And the third thing is about patient outcomes, right? And can we use technology, data, in a way that can drive positive patient outcomes? Because at the end of the day, if you talk to patients, they will tell you that in spite of all the advancements and in spite of all the money that is spent, the outcomes are not exactly the way they would like to see them, right? Essentially, there are many aspects to this, obviously, this particular problem, but that's a third dimension to this. So access and cost of healthcare, related to that is obviously productivity, avoidance of waste, and driving sort of operational and clinical outcomes, and then making sure that we can tie that to patient outcomes in terms of both diagnosis and treatment is going to be are basically the challenges that everybody's has been talking about, right? Even pre-pandemic. And then last year the pandemic hit. One of the first things that we saw across the board is it drove a set of changes that would have typically taken 4 or 5 years in matter of weeks, literally. But because of all of the social distancing norms, as well as safety precautions that had to be put in place so that we can protect the front line, as well as the patients, it's also driven some significant changes in the care delivery models. And in fact, if you now sort of look back over the last 1 year, it's unbelievable that healthcare was being delivered the way it was being delivered before the pandemic, and this now seems to be the new norm, and very unlikely that things will go back to the old ways of delivering care, right, in general. But what we have seen typically is we have seen a massive push towards a few things. First one is virtualization of healthcare itself, right, or care delivery model, wherein instead of a brick and mortar hospital, you have now a situation where you have telehealth, you have doctors consulting with the patients on on video and using different other tools, but without the patient having to actually walk into the hospital. But there's also a significant aspect of this, which is distribution of the care delivery model across administrative boundaries, right? So, for example, before, if you're a health system, you pretty much had the labs, the imaging, as well as the rest of the, sort of care pathway within, most of the times within the premises, or at least within the health system. All your IT systems were within the health system. There's PACS or EMRs or, data repositories, lab information, and so on and so forth. And what we have seen now is a significant push to sort of distribute the entire sort of care delivery model. So if you look at the patient journey, instead of the patient journey, sort of starting at the hospital and sort of ending logically, at least at the hospital, now we are basically saying that the patient journey may be remote, right? May be distributed across locations. A lot of B2B activities, a lot of acquisitions and mergers, where hospital systems are sort of either having partnerships or buying out players in the local and sort of rural areas and so on and so forth. But a significant push towards distribution of care delivery models, where instead of the care being delivered inside the premises, it's now getting sort of spread out across the premises, but also spread out across administrative boundaries. So now maybe the imaging is not necessarily done within the health system. It's probably done by another provider. Maybe the lab is done somewhere else, right? And it may not be in your sort of administrative boundary. But as a health system, you would like to own the patient journey still, okay? And would like to own the patient outcome and the relationship with the patient. And that's the whole aspect of virtual health in general, right? So I think that's a significant change that we are seeing. And the third aspect, which is related to virtual health and distribution of the care delivery model, is home health, right? And this space obviously is exploding, as many of you would have probably already experienced, because people are realizing that there's a lot of monitoring that can happen at home. There are lots of wearable devices coming into play. These wearable devices are getting more and more sophisticated. You can run more AI on the device or at the edge inside the home. You can actually glean a lot of information, from these sensors and devices for the patient, and then essentially upload that information, on a cloud or into a health system, essentially. And that provides a significant sort of lift to the whole care continuum, right? Where, pre and post admission, there can be a significant amount of monitoring that can happen, which can result in cost avoidance. It can result in avoidance of readmissions and so on and so forth, drive better patient outcomes. But it's not just monitoring, it's also all of home health, right? So people are being taken care at home, right? People are setting up like the home hospital, or the home ICU or so on and so forth. But I think we are in a very interesting phase at this point in time where, the assumptions about how care gets delivered are fundamentally changing. And I think it's also aided by the regulatory processes and so on and so forth. So we are going to continue to see a massive shift there in terms of care delivery models overall. So we've been sort of at GE Healthcare thinking about this hard, and I'm pretty sure many companies are. There is a lot of work that is happening in this space. One thing that we realized very quickly is, for us to make progress from a digital perspective and from an AI perspective, obviously there are a few things that are very, very important. And first and foremost among that is data, right? And if you think about what has been happening with data across the health spectrum, okay, for a given patient, you can see that there is a massive fragmentation of information across different department silos or different care areas for a given patient. So if you talk to an oncologist today, they will tell you that there's swivel chair between 5 or 6 applications for a single patient. Okay, and mostly because the applications that they're working on, in silos, are looking at siloed parts of the sort of data. But the interesting thing is most of the time, all of those 5 or 6 silos are within that health system. Okay, so there is a very significant fragmentation of information that is there. So it starts there, right? So there is a massive opportunity here to first and foremost be able to aggregate this information in a way that there is a comprehensive view of the patient, a 360 view of the patient that's available. And then, that comprehensive view then needs to be processed, right? And that process requires the processing of that information obviously requires a set of tools, right? And that's what we can call it very simplistically. You need some sort of an AI, environment where you can build models or you can deploy models. You need advanced visualization tools, you need workflow tools, you need other sort of orchestration tools, you need DICOM connectivity, you need connectivity through HL7, through multiple other sort of IT systems within the health system. And in case of virtual health, now you're talking about connecting this information not necessarily within the premises, but also from maybe remote clinics or other partners where the patient might have parts of his or her journey as a patient journey, where all of that information needs to be mapped, right? There may be cybersecurity, right? There may be cloud connectivity, and so on and so forth. So there are a number of sort of building blocks, you can say, that are required, apart from the data itself and aggregation and curation of the data, which will allow us to then start building workflows and new applications that can truly drive some of those aspects that we talked about, right? Can we drive access, right, through telehealth and so on and so forth, and remote patient monitoring and and the likes? Can we reduce the cost of healthcare? Can we reduce wastage in the system, or can we drive better patient outcomes? Right now, all of these are going to be some workflows, right? Or some tools that are going to be used, or some applications at the end of the day, right? And those applications are to be built, but to build those applications, you need the data and you need all of these building blocks, right? And essentially, that's what I call a platform, right? Because at the end of the day, what is a platform? It's not just compute and memory and storage and whatever is required from a cloud connection perspective. But I think is the layer of this software that sits on top of it, right? Which has a very specific healthcare persona. Okay. That's what I call the platform. In fact, when I joined G Healthcare 4 years back, when we conceptualized the Edison platform, one of the questions that I answered most often, right, almost for a year, is what's the difference between Predix and Edison? One is an industrial automation platform, one is a healthcare platform. And I think the important thing to understand is this service set, the building blocks, right? The healthcare persona very specifically. That's what is the platform, right? So the ability to connect to devices, the ability to connect to different systems within healthcare or within a health system with different IT systems, different interfaces, so that you can pull in the entire context of the patient and aggregate it, right? And then use these building blocks to really construct the workflows and applications which will drive the outcomes that we talked about. Now, that layer of software is what we are talking about from a platform perspective. And I think this is a very critical piece, right? You can choose the platform that you want to work with, but it is important to pick a platform. So it has a huge role to play, because otherwise, okay, what you're going to find is you'll still need the applications and you'll still need the workflows to drive the new care delivery models. But each of those applications would be siloed, right? And each of the applications or workflows would be siloed. And essentially what it does is it replicates a lot of logic in multiple applications if the applications tend to get siloed, right? And it's neither cost effective, nor is it sort of efficient from a pace of development perspective, nor is it efficient from a deployment standpoint, right? Overall, we strongly believe that you need a very strong sort of platform approach, to this particular problem. We built out the platform. We built out about 130, 140 services around it, including the data aggregation, aspects of it, and connectors to different connection points within the health system apart from the devices. And as I said, many services which will aid the application and sort of delivery of this application as a part of the care care model. And then I think what I would say, what is really, really important, as you look at these services, is you need to apply the domain knowledge, the specific clinical knowledge, and work hand in hand with the clinicians to really construct the workflows so that you can help them, deliver the care delivery model that we talked about earlier, whether it is virtual health, whether it's distributed health, whether it is home health, virtual sort of tele ICU, home ICU, or home hospital. At the end of the day, or remote patient monitoring, all of these are clinical processes that need to be run and patient outcomes that need to be driven. So when you are actually developing the platform, that clinical input and the domain knowledge is extremely important, right, to factor in, because what we realize is that whatever you do from an AI perspective or data perspective, if you can't fit it in the clinical workflow, it's almost useless from a provider perspective, right, in general. And it's a similar story for payers, right? It has to fit in that patient journey overall, and in the processes that the payers have and the providers have, or the processes that are in between the payers and the providers. So I guess that's where the whole sort of domain expertise come in, because you can't really build a platform or an application workflow in isolation. And to do that effectively, if you can sort of open up the platform and create an ecosystem around it, but make sure that you work with the providers and the payers to integrate the ecosystem in their specific environment, right? That I think is the most effective formula. So in a nutshell, I would say, look, we are at a very challenging time in the history of mankind, I would say. This pandemic has been absolutely shattering for people and populations. There's a need for dramatically changing the care delivery models and the effectiveness of it. And I think digital, AI, analytics, and technologies in general, platformized together, right, can really help us solve many of the challenges that face the world from a healthcare perspective today. I want to thank you for the opportunity to speak here, and I hope that you found this useful, and have a great day. Thank you.
Hey, thank you, Amit. That was great. Amit's actually one of the HC13, one of the founders of our CDO Digital Voices organization. And so super insightful, because as technical as the solutions are that we all have and we all can create, it still comes down to the experience. I was just taking some notes, the clinical workflow, how does it all fit? The patient journey, how does it fit? It's very much a common theme, common thread that you've heard through our first three speakers, unsurprisingly, right? And unrehearsed. So these speakers did not see one another's scripts or anything like that. So it's just kind of unfolding like that, but I don't think anyone would be surprised by that. So it's very, very cool. And thank you, Amit, again, for being one of our founders. And another founder is Rajiv. He's the Senior Vice President, CDO of Anthem. He's going to be talking about optimizing AI in the payer space specifically. And he has a great background too. You can look all these people up or on our website. And he comes with many, many years experience at Deloitte, heading up analytics and different parts of healthcare. And so he really understands just the power of data to provide the sort of transformation that we're all thinking about. And so without further ado, I want you to meet another friend of mine, Rajiv.
Pleasure to be here today. I'm going to be talking about optimizing artificial intelligence and using it for health and improving all of our health across the board. So the question that's often posed is how does artificial intelligence do that exactly? And we know the potential for it in all other industries. It's all around us, whether it's in financial services or retail, banking, and driving. If you're fortunate enough to drive any of the autonomous cars and self-driving cars that have already hit the market, artificial intelligence is in fact driving and making key decisions that are life and death. So it's a mature technology, and it's all around us, and it's going to get even better in the months and years to come. And its application in health has got huge implications. So let me maybe outline the reason why the application in health has got such vast potential. It all starts with data. Healthcare data is hugely fragmented, but it's also something that's growing at an exponential clip. And at Anthem, for example, our healthcare data doubles every 73 to 80 days. So if you think about it, we already are sitting on vast amounts of data. We have claims data for over 70 million lives. We have clinical data for over 15 million lives. We have lab data. We have data from our watches and our Fitbits and our devices. And if you put all that together, the ability for humans to keep pace with that amount of data is nearly impossible. So we need a better solution. We need to find a way to leverage all of the insights that are buried in this data to really make a difference with our consumers' health. So that's exactly what we're doing. So let me maybe describe the different categories in which artificial intelligence is being applied. And here's what they are. Number one, it's being used to automate key business processes. Like any other industry, healthcare has a number of processes that are complex and interconnected and dependent. And to get any one thing done requires collaboration with a number of internal and external stakeholders. Artificial intelligence essentially is automating those cumbersome, labor-intensive processes. So let me give you a few examples. Claims processing. The way claims processing works is, us as consumers, may see a doctor. The doctor then would essentially submit a claim that then Anthem has to review, or any other insurance company has to review, and then make a determination as to what the payment ought to be for that. And that's the bedrock of kind of how the healthcare system works in the US. And hundreds, if not thousands, of people work on these processes across the ecosystem. Providers have staff, insurance companies have staff, and of course, consumers have to make sense of it all. With artificial intelligence, we're now able to automate a vast majority of the work that happens with claims processing by using a variety of techniques like natural language processing, machine learning, and applying it to the adjudication of claims to make a determination as to whether a claim needs to be paid, or if it needs to be adjusted, or if there's a question that we need to resolve with a provider. All of those things could happen through the use of AI, and it's creating tremendous efficiencies across the industry. And that's just one example. Claims, beyond claims, we can also apply, and we are applying, artificial intelligence to things like underwriting, prior auth automation, billing, payments, et cetera. All of those things coming together create a huge amount of efficiency. So think of category one as the application of artificial intelligence to automate labor-intensive processes. Category two is super interesting. With the amount of data that we have to continually mine that to get insights. And as the data grows, the number of insights grow. And using AI, we're able to find insights that can create additional efficiencies. AI might suggest that if we did a process, using a different technique or a different method, we could be even more efficient. So it's almost like we're automating it in the first place, but with the data, the AI is identifying additional opportunities for automation. And then AI is also identifying opportunities for growth. It's about how do we acquire new employers, new consumers, how do we expand our relationship with our brokers and our producers? How could we do better business with our provider partners? So AI is uncovering opportunities, which then we're able to translate into growth and new sources of value for our company. So that's category 2. AI is also being used to sense and identify opportunities that perhaps are far off on the horizon, but maybe just on the cusp of kind of disrupting our industry. We often sort of think of these videos and other things on social media that have suddenly gone viral. One day it's someone posting a video, and then next day it was 5 million people that have viewed it. So that kind of a disruptive viral moment when it comes to technology and events are kind of hard to predict. But with AI, we're able to systematically sense what a trend is that something might turn into something that's impactful for our industry, and systematically analyze it to figure out how we would leverage that as an opportunity, or put it on our radar to say, yeah, that's something that we need to worry about, let's say a year from now or 2 years from now. So that's about sensing and shaping and detecting trends. The one that's most exciting to me personally is engagement. AI shapes the way in which we can personalize the engagement with all of our stakeholders, us as consumers of health, providers who provide critical services to our consumers, and making each of those experiences very personalized and grow from each experience and make the subsequent one better. So 2 examples of that. At Anthem, we use something called Sydney. Sydney Health is a member engagement app that's used by all of our consumers. So think of it as a one-stop shop for all things health and service. The way that Sydney is constructed is it starts again with the data. So it analyzes all of the claims data, the clinical data, the lab data, and the device data to offer up unique and tailored insights, almost like a daily digest. So imagine you wake up in the morning and Sydney says, "Good morning. Here's kind of what we have on your plate for today. We noticed that you didn't sleep as well. You're not as well hydrated. We suggest looking into well-being choices that might address that." A simple use case. Something far more complex might be we have a number of signals that we're setting off that might be indicators of health. So if, let's say, I'm prone to certain chronic conditions, Sydney might detect that 6 months in advance, a year in advance, and say we're kind of seeing some patterns that might lead us to believe that a year from now or so that you might be subject to this, or you might have this chronic condition. So knowing that, what's the best mechanism for engaging our consumers? Clearly, we don't want to suddenly pop up a text message that says you're going to get a heart attack in a couple of months, and that's probably not going to go over well. Instead, what we have to do is serve up educational content to make our consumers aware of what choices they could make, why we believe they're at risk for certain conditions, and gradually sort of get them to act on the insights that our data is able to generate. And then personalize that engagement to get the highest sort of effectiveness of consumers actually changing their behavior to do something about it. And then on a continuous basis, we're personalizing that engagement. So my Sydney experience, someone else's Sydney experience, Ed's Sydney experience, they're all different, and they're all sort of treated as an N of one, which then gets better and better as people use it more and more. And then the flip side of that in healthcare is, what do we do for our doctors? So for the Anthem network of providers, we use something called Health Operating System. Health Operating System is designed to solve the problem of data interoperability between different providers and the ability for consumers and providers to collaborate more effectively, as well as Anthem and its provider network to collaborate more effectively. And Health OS consists of kind of 4 key components. One, again, is the interoperable data foundation and a new security architecture that we've built called Zero Trust. And then, very importantly, it provides a workflow and applications that are built on that data by Anthem and by third parties to allow for providers and Anthem and our consumers to all work together as one common collaborative family, if you will. One example of that is a digital scribe. So imagine you're in your doctor's office and the doctor says, I'd like to record this visit so that I can just focus on treating you rather than taking notes and looking at my computer. So this device would turn on with the patient's consent, record that visit, and using techniques like machine learning and natural language processing, at the end of that visit, create a summary. And that summary could be reviewed by the doctor, and the electronic medical record could automatically be then populated with that information. Using the same recording and the same transcript, again, natural language processing and machine learning could submit a claim to Anthem and include the clinical data that supports it. Now, a normal process that probably takes 15 to 20 minutes after that patient visit for the doctor to kind of complete the documentation, and probably a couple hours to then submit the claim to Anthem, could all be done in real time at the conclusion of that visit with far greater accuracy. So these are things that are already in production with Anthem, and we're seeing much success. That's just one example. There are other things like as one of our members is preparing to see a doctor, as we become aware of that visit, we can essentially prepare a doctor to be more informed about the patient's conditions, patient's history, what's happened prior, all the drugs, and all of our predictions. What do we see as key health risks for that patient, and put that information at the fingertips of the provider, so that as they're seeing the patient, rather than reading the notes from the last visit or asking questions, you can dive right into the specific conditions that are of concern, to that doctor, and ultimately make recommendations, based on their judgment. And once that diagnosis or that treatment plan is developed, we can record it, digitize it, make it available to consumers so that they can follow it on their app. And then the doctors can follow their progress and make suggestions, as well as the machines can then learn from each suggestion and start to augment the advice that the doctor is providing, as well as personalize that experience for that member, through the continuous use of Sydney. So those are just some examples of how AI is being used in health today. I think we've just scratched the surface. As we look at the future, we can personalize medicine and therapeutics in ways in which we've never been able to do. For example, drugs that are created for us are based on randomized clinical trials, and those methods work at a population level and not at an individual level. So imagine if we're able to take all of our clinical data, all of our genomic data, and other omic data, and then precisely create the therapy that works for our genomic and clinical information. And that could be done for everyone across the globe. Well, it's possible to do that, with the use of AI, and then continue that level of personalization, so that we can ultimately, bring to life precision medicine and more advanced therapies to life to fundamentally change the way in which humans and medicine interact. So if you step back from all of this, all of these things are in flight across different parts of the globe. Anthem is viewing this as a platform play, where we've created a digital platform into which all of these innovations could be connected, and then we could bring these connected experiences and connected therapies and digitized therapies to our stakeholders in ways in which have never been done before, ultimately to simplify the healthcare experience and make healthcare far more predictive, personalized, and proactive, moving us away from what's been a largely reactive system to one that's simple, healthful, joyful to our consumers, and ultimately keeps everyone healthy. Thank you.
Rajiv, that was really, really good. And what I loved the most was the actual examples. A lot of times we talk AI, ML, digital transformation, name the buzzwords. And then when you like really dig into it, it's like, what are you really doing? And there's not much, but you all are to be applauded in your vision, what you're doing, because not only real time, but also, what you're thinking about in the future. I loved it. Again, the common themes, as I look at my notes, all around engagement, the personalization, the engagement for the clinician, preparing the notes in advance, letting them know what's the most important about this particular patient, because we all know how that process works today and it's broken. So that's awesome. And just where you're headed, things that you're doing is fantastic. And again, you mentioned platform. And so again, common themes throughout. And again, not surprising, Chief Digital Officer talking about things that we're doing, all about the experience and all about the platform. So thank you. Our next guest, we have another clinician. So Dr. John White kicked us off today. Obviously a physician. We have a nurse. Christy has been a nurse practitioner, as a master's in nursing and some post-master education. She's a fellow Texan. So I'm speaking to you from Dallas, Texas, where I've lived since around 2007, I think. And Christy's been down in Austin, and she is the senior vice president for the Center for Digital Health, and recently announced also the CEO of MedExpress, part of Optum Health there. So she's amazing. You'll see for yourself. I keep telling you that these people are amazing, but I think you'll figure it out yourself. So she's going to be talking about exactly, the purpose of why we organize Digital Voices, the CDO organization for CDOs across health and life sciences, trying to break down those individual silos that exist in a lot of professional organizations. And so she's going to be talking about payer and provider merging in technology, right? Because that's what, a lot of our payers are doing, and also on the provider side as they extend themselves sort of into the payer community. So with that, I want you to meet my friend, Christy. Hey, Christy.
The resilience and innovation that emerged within healthcare industry over the last year was nothing short of extraordinary. The usual virtual care clinics shut down all over the country, and virtual care became the staple of how we were going to deliver care in a safe way to millions of people across the country. And from one perspective of the largest payer in the country, we went from 1 million telehealth visits pre-pandemic to 22 million last year. And in the largest ambulatory provider network, we had in 2019 less than 1,000 telehealth visits, and in a matter of weeks we put 17,000 providers onto telehealth so they could extend services to those that were in need of healthcare services. And in the last 9 months of last year, delivered over 1.3 million telehealth visits. So last year was an extraordinary year and a time for virtual care to take center stage and to really be positioned as the healthcare delivery model for the country during this pandemic. And it opened the eyes to so many people of the possibilities and the promise of what technology has to offer. This immersion into telehealth was really a awakening and of the possibilities that there could be in the future of how telehealth could play an important critical role in access and engagement and ongoing care. It wasn't anymore seen as just a novelty of something that was used for minor illnesses or only for academic medical centers for subspecialty care. It was really being used for all ages, all specialties, all age groups, for acute, chronic, for the young and for the old, and for all types of conditions. And so the possibilities were there. And the other part that we saw happen was that we saw a change in who was willing to try and use telehealth. So pre-pandemic, it was younger populations, the 25 to 33, 34-year-old that was using telehealth and was the consumers of a more convenient access to care. But during the pandemic, that age shifted, and it was 55 to 63. And so we saw a real opening of the eyes, and some of the biggest skeptics, or for those that thought, oh, it's not for me, realized that this was an easy way to get access to healthcare. And for healthcare providers, they saw the possibilities of what they could do with technology and using this as a modality to do what they do every single day, to think about how in the future would I use telehealth in my practice? When would I see somebody in a clinic, or when should I see them? virtually. And that's what I think is the most exciting part about what's coming forward, is that I feel the greatest opportunity is yet to come in this symbiotic relationship between the physical care setting and the virtual care setting, allowing people to have convenience but connect to their provider and care team. So it's not just any care provider, it is their care provider that's available virtually or in person. So I think that's the really exciting piece as we move forward post-pandemic and thinking about how do we take the learnings of 2020 and really reinvent primary care, reinvent the healthcare delivery system to be convenient, but to also be focused on good utilization of our healthcare resources that are so scarce. The benefit of using these digital health tools allows the providers to reach and engage and build a trust with patients in ways that cannot be accomplished with infrequent visits to the doctor's office. Healthcare professionals have the opportunity to take this hybrid model of care with both virtual and in clinic and in home and maximize the experience and have more frequent touch points so that we can really change behavior and healthcare outcomes and really start impacting the total cost of care. So when I think about the future, I'm most excited about this integrated care model of virtual and in person in the home, where there is a symbiotic relationship. We have a lot of work to be done to make that really happen. We've seen these numbers surge last year of virtual care visits, and they are declining, but they're declining because for a couple of reasons. One, there was deferred care that needs to come back into the clinic and be taken care of. But we're seeing this disbursement of the care needs between virtual and in person as the two coexist. And so as we create the rules and the algorithms that determine what is the right setting for care, that's where we'll start seeing us stabilize and use both models for the new model of healthcare going forward. And so you're seeing even health plans creating new programs and new health plan designs of a virtual first program. And so I'm really excited to see what will happen when all care is managed virtually first, and only if needed would a patient come into a clinic or into a physical location for care. And so when you start flipping the model and thinking about the possibilities, what percentage of care does need to be done in person? There's always going to be a need for in-person care. So hear that, but the blend of the two and the continued advancement of technology, the continued awareness from consumers around the possibilities of how to use these tools and how to connect to their care team and to be a participant in their own health is going to be exciting to see where these plans go. And so with technology now, patients can be matched with a care team, a virtual care team, which is curated around their needs. If they need a dietitian, if they need a behavioral health specialist to accompany their PCP and their primary care provider, then this allows us to be able to do that and share resources across the country in a way that we've never been able to do when our healthcare model was always driving into a brick and mortar. So the new level of convenience and care coordination that can be afforded will allow us to manage patients in a more effective way. It'll allow patients to have their preferences matched. So if they want to see a provider that speaks a certain language or match with a certain kind of specialist, then the technology allows that to happen much easier than ever before. Leveraging devices and home kits and home lab self-collection kits. Those are other things that we learned during the pandemic as we were really advancing the lab testing industry and what care could be done at home. And so the benefits are much broader than just convenience and access. It's much more than just a video visit. It's this combination of precision navigation, matching, video visits and chat that really are going to transform the healthcare system, but also recognizing that in-person care is a part of this. But if we flip the model and do as much as we can in a virtual environment, the potential is there for something really radically different and much better. It helps minimize the geographic disparities that so many have had as they had to travel long distance to get the health care that they needed. With 60 million Americans living in rural areas, it reduces those transportation barriers, and it it's the third most common reason that visits are canceled to see a healthcare provider is because of transportation barriers and difficulties with the distance traveled to be able to get access to care. So it can help remove that. So virtual care is going to help us create a new model of care moving forward. And we have an amazing opportunity to take one of the most difficult times our country has had dealing with a pandemic, take lessons learned from that, and really embed technology as a modality of how we reach patients in this new reinvention of primary care. Thank you for your time today.
Christy, thank you. That was super. I love the concept of the integrated care model because we used to use that word meaning something completely different. But today, what we're talking about is really the merging of the virtual and the physical. And I call it an art. Like, how do we get it precise? And you touched on some of those things about the patient being a participant in their care, something that we've really struggled with for many years. But I think, when I think back to some of the other speakers, like what Rajiv was talking about with Sydney and what you all are doing, you're really starting to hyper personalize the experience, give people choices. And I think that does create this connection. It does create the opportunity for more engagement. And then the other thing that you touched on, and this has been going on in the chat as well, so I just want to bring it up really quick, is the whole concept of health equity and social equity. And I quoted a good mentor of mine, Ram Raju, now with Northwell, formerly CEO of New York City Health and Hospitals, who says there's no social equity without health equity. There's no health equity without social equity. I mean, the two are just tied intricately together. And so one thing that can be done by leveraging some of this technology where people have it is really to eliminate some of the biggest reasons why appointments are canceled. And that's the whole transportation thing. So whether we're talking about a rural environment or even in a big city like New York City, it's difficult to move around. So virtual care can definitely help and is helping there. So thank you for that insight. Our last speaker, but certainly not the least. All of them are so great. We had like trying to figure out how do we stack them all up. But as my friend Shweta, she is from Google. She is the global leader for biopharma. Again, we're Digital Voices, which is across the spectrum, health and life sciences. That's why you heard today from providers. You heard today from payers. You heard from biotech, life sciences, just the entire continuum, because that's who we are. We're CDO organization created by CDOs for CDOs, and we all live the talk. We all live the experience. So she's going to talk about digital transformation in biopharma, right? That's something of high interest to me because I know provider side pretty well. I've learned payer side over the last year and a half a little bit more, but I'm still pretty deficient when it comes to my understanding of life sciences and biopharma. So really looking forward to hearing her speak. She's alumni with me of the Cleveland Clinic way back when, and then most recently a leader with Genentech, and in the last few years with Google. So welcome and thank you for being with us.
Hello, everyone. Thanks for the opportunity to be spending time with you today. My name is Shweta Manyar. It's a privilege to be speaking about my thoughts on the industry, and thank you sincerely for the invitation to be here today. I've been given the challenge to share the future of pharma in my short time that I have with you today. Today, I will talk about the potential future of the pharmaceutical industry, which is actually more than just the pharma companies. My experiences and roles have allowed me to have a holistic view of the life sciences industry. And unlike the way our industry and ecosystem as a large is structured today, I believe that we will be organized with the patient at the center, not the ecosystem or the individual institutions that are part of the healthcare and life sciences system. And so in order to be able to share some of what is to come and what we see in the future, let me share some of the changes and progress that I've seen and observed in the last 18 months. I'd be remiss if I didn't address the elephant in the room around the industry dynamics. The life sciences industry was significantly impacted in the last 18 months due to COVID-19. And it is no secret that COVID-19 changed the world in a way that we could never imagine. And sadly, we weren't prepared for. But what's the silver lining is the pandemic has sped up the evolution of the life sciences industry. Suddenly, speed was the metric that life sciences was measured on. And that's never been something that a pharma company has ever been known for. Some of the other challenges were that biopharma and device manufacturers were adjusting their forecasts to factor in things like the impact of a delayed launch, how the pandemic disrupted clinical trials and its data. Additionally, there was renegotiation of contracts with health plans due to sharp drops in volume, etc. So all that to say, there were some major changes that we're seeing in life sciences that they have to deal with, and especially as challenges surfaced very quickly in the past year. Another area is manufacturers of drugs and devices are partnering more with market access stakeholders to ensure the continuity of care for patients. So real-world data and social data inputs are becoming increasingly valuable to manufacturers. And now as it relates to precision medicine, or more loosely personalized medicine or personalized healthcare, or some variation of this term in many larger life sciences organizations, we're seeing them use a digital-first strategy to focus on patient-centric approaches starting from the bench. So now life science companies are becoming a steward of the user experience by deploying value-based, customer-centric, design-based products. And while all industry supply chain efforts have come under scrutiny, as many were thinking about where to get their toilet paper and Lysol wipes from, it also brought to light an inadequacy for the life sciences supply chain as well. What has emerged as an issue is the visibility gap. And so overall, we're seeing a faster appetite to embrace digital and data and they want to use real-time information. And lastly, COVID-19 brought about unusual and sometimes unexpected collaborations with government and regulators, and a collaboration between historically competitive companies, particularly around research efforts. It's an understatement to say that this is an exciting time for life sciences. And the speed and insights that the last 18 months forced on life sciences is a testament that it's not going to go back to the way it was. And a lot of this industry is going to have to transform to remain competitive. And this is actually why Google Cloud is focused on the pharmaceutical ecosystem. We're offering these modernized solutions that are reducing data errors, inefficiencies, and disconnects in such a highly regulated processes and environment that can accelerate the pace of innovation. But let's talk about now the future, and the future of pharma, and I'm going to break them down into 6 key topic areas. So the first I'll start with is personalized treatments. In the future of health, the concept of mass producing drugs is likely going to decrease. Instead, I see tailored therapies being developed to cure or even prevent these diseases rather than symptoms. These therapies are being developed by data-powered insights, so i.e., the concept of medicines for N of 1. This level of personalization is going to require a large combination of data, including real-world evidence and new clinical trial formats to identify dosing, etc. Because the massive real-world evidence that's going to be required to develop these personalized treatments, I believe that these diseases that personalized medicine will be able to serve first are going to have to be where there are large sets of real-world evidence available to inform dosing regimens today. We'll have streams of data, which will be combined with a variety of other meaningful inputs to create a highly personalized view of a patient's well-being. Another major change is to watch out for is the prevention part. Early detection technology and understanding of genomics and data are likely going to enable interventions that will stop a disease before it starts or at a very early stage. The second, what I want to talk about is the supply chain. If we look at personalized therapies, then there is a strong need to link a deep insight into how these therapies are going to be traveling through the supply chain. And while we are dealing and remedying the cold chain requirements for climate-sensitive medications, this is the time that organizations are also looking at the future of their supply chain. An interesting observation from Google's perspective is that there's a retail-like expectation of the life sciences industry that I see that's happening for supply chain. In order for outsourcing solution providers to win bids, they're trying to provide that retail-like transparency. Digital platforms are being created to give customers real-time insights into commercial and clinical supply chains. This is the only way to embrace AI, artificial intelligence technologies, and breaking down the silos around asset management. While this is a large cultural change, I've seen that the barriers tend to fall once the network value evidence becomes apparent. So when we think of supply chain, What you and I might be thinking about is around ventilators and PPE, but what about things like the drug recall process? It is right now a very fragmented process, and that network value includes serialization data, IoT devices, RFID sensors, and enterprise resource planning, or ERP systems. And in the near future, this is all going to be a key tenet of how supply chain will digitally transform. The third area is going to be around manufacturing. We're seeing organizations are preparing for the new normal. While the past decades have been characterized by manufacturing moving more and more to lower cost offshore locations, I believe that we're seeing a reversal of this trend, with manufacturing returning back to high cost countries. This is going to have a profound impact on the entire manufacturing ecosystem. Most of all, the shift to higher cost locations will lead to an acceleration of automation and digitization to prevent overall manufacturing costs from going up. The workforce capacity is expected to decline due to age, but the shortage of these skills also in these respective high cost countries. Moreover, it's going to lead to a fundamental restructuring of supply chains around more diversification and localization. So ultimately, this is going to increase the pressure for pharma companies to innovate, especially around digitization and the Industry 4.0 in manufacturing. So a key part of increasing efficiency is to leverage technology and capabilities using data analytics and AI to power those advanced insights and actions. An example I often use outside of the industry, which is just as applicable here, thinking about a connected factory. So be that baby food, beer, or the pharma industry, there is a lot more in common than you might think. You have a unified data analytics and AI for manufacturing systems, intelligent automated quality and assembly conformance, the ability to detect safety violations and conformance, and then one uses that information to create predictive maintenance measures and efficiencies for operational excellence. In that cycle, you can see you can also have, intelligent controls to scale and more efficiently control energy consumption, use natural language processing for an interaction with factory equipment. So you can see the possibilities are endless for the pharma manufacturing world. Let's bring it back to the medicines and the patients that we are ultimately talking about. That brings me to my fourth topic, which is going to be around digital therapy. When we see digital therapeutics coming from a tech company, we see this not only as only thinking about the pharmaceutical part to manage a disease, but combining that with monitoring and insights based on lifestyles, and then the intervention. Think about heart disease or diabetes. So what I'm sharing is already happening today. So what about the future? The future depends on reimbursement and the adoption without expanding the health disparities gap. So not just for the worried well, who generally use this monitoring technology as it is. Let me move on to number 5, which is around prediction and therefore prevention. The way we can predict breast cancers earlier today, more than we can 10 years ago, allows for earlier treatment. I expect that we're going to see predictive technology advance, particularly for oncology and rare diseases, and particularly for ones that can be linked to genetics and lifestyles. Lifestyles include nutrition. The microbiome market is booming with a massive increase of funding. So not just having consumers and patients understanding their microbiome, but for a pharma company, think about the treasure trove of data and what that will drive in terms of preventative disease discussion in the future. And I can't talk about prevention without mentioning vaccines. While vaccine development has been a top in the headlines, hot topic in headlines, I'm talking about the delivery of vaccines. Pharma companies, particularly those who have come together in the last 18 months around the vaccine for COVID-19, are now open to discussions around combining multiple vaccines into one delivery. So that's the first part. And the second is the mode of delivery can be actually more painless. We've seen technologies being developed for a patch that has microneedles that are skin surface level deep only that can be administered by yourself. And lastly, let me talk about personalized or precision intervention. While we discuss prevention, which is something the closest thing that a stereotypical pharma model could attain, customized treatments would be next. But let me talk about what I think is going to be the hardest for a traditional pharma company to build into their roadmap. and that is preparing for precision intervention, thinking about tissue engineering, robotics, and technology that could actually eliminate and reduce the need for medicine to begin with. So I'll leave you with a bit of advice to the leaders here who hold the precious responsibility for their organizations in the future. Now that life sciences are taking digital very seriously, those we see who will win 20 years from now are the ones who are reimagining their business models, taking what we've talked about today, building prevention, prediction, and interventions. And I'm not just talking about pure medicines, but the artificial intelligence, the diagnostics, the entire ecosystem into their business models. All stakeholders within life sciences ecosystem have enormous digitally enabled breakthrough opportunities ahead. These benefits will not just come from a large decrease in data integration complexity, or a decrease in traditional technology in each company, or how we're breaking down the silos, but also from the economic power of scale, of partnership, of responsiveness, of the visibility and the transparency across the entire ecosystem. And that's how I began today's talk as well. I know I'm short on time, so let me leave you with one thought. It's a privilege to reflect on what this industry is going to be like 20 years from now. And thank you for taking the time to see it from someone who's viewing it from the industry as a whole. But I'll end with a bet that 15 to 20 years from now, you're not going to go to your local drugstore to pick up your prescription. You'll pick up your personalized therapy, a medicine that was made just for you, a manufactured compound that is based on your exact genomic makeup, microbiome, and metabolome. Or maybe you're just going to watch it being made digitally through your device and know when it's hitting at your front door. I appreciate the time today, and I've enjoyed listening to my colleagues speak, and please enjoy the rest of the forum. Reach out if you have any questions after today, and thank you once again.
Thanks, Feta. That was a great way to end our Digital Voices 2021. Thank you for everyone hanging in there. It was jam-packed full of just excellent things across the continuum. If you want to join us, there's no cost. It's Digital Voices. You'll find us on LinkedIn. You'll figure it out. And just briefly, the themes. Well, one, I really like the future prediction there that Shweta made for us. I don't know about the self-administered shots. I've done that. But yeah, that sounds pretty cool, all the personalization. So really, there was like 5 Uber themes: patient experience, clinician experience, design thinking. A couple of people mentioned it specifically, but to me, that's all I was hearing when people were talking about the engagement and experience. The platform, right? We heard several of our speakers talk about platform, and I gave some examples online how that's transformed other industries. And then finally, I think there's a great opportunity for us as leaders to leverage this technology to ensure to be part of the solution for social equity and health equity. So thank you for joining us. I know went a little long, but man, what great stuff. I would hate to have cut any of that out. Thank you. Keep in touch with us. Join us. And let's transform healthcare together, breaking down silos across health and life sciences. Thank you so much. Have a super day.